Let me know. Is anyone here? Okay. The first, we're going to go over a little bit of the anatomy and physiology that hopefully most of you are familiar with. It can get a little bit complicated with neuro, and I realize that. That's why I'm going to kind of do a quick refresher. Because some of the things that we all should be aware of, especially in advanced practice, is that knowing the anatomy is completely relevant, especially with some of the disorders that we're covering. If you know the anatomy well, the disorder is very simple to understand. It makes it much easier. If you don't know it well, then it makes it a lot more difficult to understand why we're doing certain treatment protocols and things of that nature. So I'm a big believer in understanding the anatomy very well. So the first thing we're going to cover is my picture of the circle of Willis. Guys, the Harbor branch, what I'll do is I can save these pictures I just drew by hand on this computer screen, the smart screen, somehow. And, you know, maybe I can send it. Yeah, apparently I can't save it till after, but what I'll do, anything I draw, because I actually, you'll see next when I lecture, I draw, I'm very interactive, but unfortunately this is not conducive to that now. I apologize. I actually really do feel bad for you guys. I don't agree, but it is what it is. Okay. Because I'm not to talk, and I really can't show you the pictures. It's really put you at a disadvantage. Again, I do apologize. The first thing I want to cover is this picture that some of you saw me drawing when you came in here. I was drawing the heart, and this is the aorta. The circulation to the brain is two systems. It's an anterior. Ooh. Whoever that was, can we try to avoid that, please? Oh, good Lord. Is that someone trying to ask a question? No, I think it's this. It could be. Is that someone trying to ask a question? I'm gonna try.
Mute their mic.
Right.
That's Claudine. Your mics are still on, so it creates background.
Listen, when you guys want to ask a question, I don't care if I'm talking, just interrupt, okay? You've earned that, all right? So anyone just click on your mic and ask whatever you'd like. I don't care if I'm in the middle of whatever, just stop me, okay? All right. Okay, the first thing I drew was the heart, and the first thing to understand about the brain, it's really, the circulation of the brain is two systems, two separate systems that merge to form the circle of Willis. A lot of students don't understand what, it gets a little complex, but it's not really that complex. It's an anterior and a posterior system, okay? The anterior system consists of the internal carotid arteries. This right here, what I'm drawing, that's your common carotid artery. Then you get the carotid sinus, and that branches into anyone want to help? What does it branch into? What does the common carotid branch to? Anyone know? No, the common carotid artery. Into an internal and external branch, right? External branch it supplies the outside of the face. The internal branch is the brain structures. So if you look at the whiteboard or the whatever, you have the internal branch and the external branch. And obviously the external branch externalizes, the internal branch internalizes. Well, the common carotid system is the anterior system of circulation. Let me change the color. This artery is the vertebral artery. It branches off the subclavian artery. That creates the posterior system. These two arteries will branch, go all the way to the foramen magnum, and then they'll join and form the basilar artery. So basically, these two are the vertebral arteries. They merge. This junction here is called the medullary pontine junction. This is the midbrain. You see my finger? No, you can't. This is the midbrain, right here. That's your pons, and that's your medulla. Basically, the vertebral arteries branch connect to form the basilar artery. That's the main portion of the circulation for, can you guys hear me? Good. for the posterior system. They travel up to the top part of the midbrain and form the postural cerebral artery. Everyone understand that so far? So basically you have two arteries come to the subclavian artery. They go up through the skull, go up to the foramen magnum, which is the big opening in the posterior fossa of the skull, and they connect and they form one big artery called the basilar artery. So it's the vertebro-basilar system. It's the posterior system that feeds the whole back of the brain, and some of the temporal lobe actually.
Can you write on a whiteboard? Is that possible?
Actually,
We don't know what you're talking about. We can't follow.
how can I do that? Let me see.
Can you write on the whiteboard?
Behind me?
Yeah, please.
Yeah, let me try that. Actually, I started drawing. Can you guys see? If I move, can you see that picture I drew?
Yes.
Okay, great. Oh, you know, that's good. Okay.
Thank you.
I haven't put the arteries in either. So basically, this is your midbrain. That's your pons, it's medulla. And this is the spinal cord. You have vertebral arteries that... Can you guys see that? This one you can say, if you can see it at least, hopefully.
Yes.
Okay, that's the aorta. The aorta has main branches. On the right side, you have the brachiocephalic trunk, which forms the common carotid artery, and then it goes off as a subclavian artery. The vertebral artery starts next to the common carotid artery right here, and goes straight up. The common carotid branches into an internal and external portion. So you have the carotid sinus. That's a place if we all massage too much or press it bilaterally, we'll pass out, because we'll be essentially blocking 70% of the blood supply to our brain. It externalizes an external branch we're not going to worry about. It's the internal branch that we're concerned about. Okay, that's the bulk of the anterior system. Whereas these vertebral arteries, they form the posterior system. So basically, we're going to focus on the posterior system first. The vertebral arteries, which branch off the subclavian, so that's your common carotid, carotid sinus, internal, external, and vertebral artery. These ascend superiorly through the transverse process of the cervical vertebrae, and they then go medially, and they connect. So let's say this is going to be a bad drawing of your skull. That's the posterior fossa right here, and that's the foramen magnum. They basically come, and right here they start to connect, and they go up into the basilar artery. So. No, they branch out to the subclavian. You're right. No, I'm just going to use this board so they can see it. So the vertebral arteries are branches of the subclavian artery bilaterally. The only difference is on one side you have the brachiocephalic trunk, which is, you know. Okay, so is everyone with me so far? Everyone here, so okay. Remember, when you think vertebral, you think the posterior system. When you think internal carotid, we think of the anterior system. Okay. Well, those vertebral arteries keep ascending superiorly, right? You can also use the word rostrally because that's towards the skull. They ascend superiorly. The more appropriate term is rostrally, and this right here is the pontomedullary junction. Basically, this is the pons, that's the medulla, and this is where they meet. When they ascend, once they hit this line, basically, they form the basilar artery, which is a very big, thick artery. That's the basilar. The basilar artery keeps ascending superiorly. These right here are the nuclei. I'm not, you're right, it's 2 lines. The nuclei for cranial nerve 3, oculomotor nerve. The basal artery then, it ends right superior to these nuclei and forms the posterior cerebral artery. So this is anterior. So that, you know, that's looking. If I'm looking at you, you're looking right at that portion of the brainstem. These will head posteriorly and supply the back of the brain. Got the whole occipital lobe and a portion of the temporal. So if someone has a stroke and if someone has a stroke, let's say, and they lose vision in both eyes, what do you think the stroke is? Not. You think both eyes, right? Which artery would it be? It would be the basilar artery, right? Which is a very rare stroke, but it happens because these posterior cerebral arteries, they supply both hemispheres. So if you lost vision in both eyes, that would be a major stroke anyway. It'd have to be a blockage before the artery actually branches off to become the posterior cerebral artery. But that's how. So it'd be a basilar artery stroke. That's how neurologists know, or they can, if they look at the symptoms in patients, they can, like somebody has primarily hearing loss. It's you know it's going to be an artery in the temporal lobe. It's going to be a branch of the middle cerebral artery. It's not that hard. The neurologists are not that smart. It's just knowing the anatomy. I'm telling you. Okay, so that's the bulk of the posterior system. I'm not going to go into all the branches because it's too much. But just know the posterior system also gives blood to the cerebellum. The posterior system gives blood to the cerebellum. So the whole cerebellum is supplied by the posterior circulation, which is what? What is it called again, the posterior circulation? Vertebro-basilar circulation, right? Okay. Oh, I hope everybody got your email. Does anyone have any questions so far? Yes, please, you answer my question. Yeah, no, you don't be sorry. Right. Well, it's to make 2, exactly. That travel around the midbrain. But yes, it's the basilar artery. Basically, you have 2 arteries converging, forming one large artery that again goes superiorly and then converted, then again breaks off into 2 more arteries. So basically, yes, you have a convergence and then you have a branching again into the posterior cerebral arteries. So basically, the 2 arteries combine, form the basal artery, which then travels all the way up to the top of the brainstem, and then branches off against the posterior cerebral arteries. And this is where the circle Willis is beginning. These arteries are really the beginning, or the end, I should say, of the circle Willis. Now the carotid system, the internal carotid system is the anterior system. So here we have the posterior system. Again, we have the vertebral, basilar, and posterior. Now again, remember this is the posterior system. So if you have a brainstem stroke, are you going to have dyscalirium? Are you going to be unsteady on your feet? Yes, because it gives like the cerebellum, absolutely. So it supplies the cerebellum. Okay. I have to erase it because I need to keep using this portion, so hopefully. Oh, let me move. Sorry. Better? Okay. Does anyone have any questions? It's actually pretty simple, trust me. I mean, there's other branches, but this is the bulk of what you really need to know. Especially when you go into neurology and primary care, is anyone interested in going to neurology? No one? Any questions this time? I'm sorry, I didn't address you guys. This is so difficult to do like this. No questions? You sure? You understand? Okay. Yeah, I will. I'll post something on there. I'll make a PowerPoint. How's that sound? I know, but yeah, I know everybody loves PowerPoint. So we could draw it on.
Dr. Ecker,
Yes.
in 10 minutes, we're gonna be off.
I know. I have to reconnect.
Another link?
Yeah.
Okay.
Oh, I have unlimited minutes now. I don't know what I just did, but okay, great. I don't know. Okay. You guys see that now?
Yeah.
Yes.
I don't know. I guess I just paid for something. Good. Whatever. Okay. But you know, I honestly, I want you to understand it now, though. I don't want you to have to. I'm gonna do it one more time because I really want you to understand it. This is your heart. You have the aorta, right? No, it's not funny. It's fine. Listen. I don't care if anyone doesn't like me repeating it. It doesn't matter. I'm the boss. This is your brachiocephalic artery. On the right side, it forms a common carotid. Becomes a subclavian artery right here, and this becomes the vertebral artery. Okay. On this side, we don't have a brachiocephalic. God has had to make it more confusing for us. Then again, we have the common carotid, and we have the vertebral. Okay. Now, just think. This is how I simplify myself. When you think of carotid, you think anterior. When you think of vertebral, posterior. Okay. The vertebral arteries are going to go up into the skull cavity through the foramen magnum, which is an accessory thing I shouldn't mention. But they're going to converge and become. So far, are you good? Okay. Now I'm going to drop from this side for a little bit. So let me actually label it real quick then. Vertebral. Common carotid, okay? I can go bigger. Subclavian. These two? It's whatever. It's always reciprocal in your body. Remember, it's always reciprocal. So this is the common carotid, and this is the vertebral. No, this is this is the subclavian. Once the common carotid branches off it, this is the subclavian. This is the brachiocephalic trunk on this side. So the right side has the brachiocephalic trunk. The left side doesn't. So this is the aorta, brachiocephalic trunk. Here, it's technically still aorta until the common carotid branches off, and at this point it becomes a subclavian. Then the vertebral branches off of that. But, you know, that's, again, just know that coming from the aorta, you have the vertebral and the carotid circulation coming from the aorta. Because ultimately, it's all coming from the aorta, right? And vertebral equals posterior, and carotid equals anterior. Most strokes are anterior strokes. The majority of them, and most strokes, same percentage of thromboembolic strokes come from the carotid, by far, internal carotid. Actually, it's really a bifurcation of the internal external carotid. Okay. You guys have that so far? Okay. Okay. So now we know where the vertebral artery is coming from. So they're going to come up through the skull, and they can converge, and they're going to form one thick, big artery called the basal artery. And again, these are vertebral. Now remember that the vertebral arteries and the basilar artery are basically right on top of the brainstem. So you have the brainstem right here. So that's your pons, that's your medulla, and that's your spinal cord. And that's your midbrain. So midbrain, pons, medulla. So it's connected to it. It's a attached to it, so it gives blood supply to these organs, obviously, also. So any stroke in the posterior system can affect the brainstem. When you say you have a brainstem infarct, you guys ever heard that somebody have a brainstem infarct? It's in the posterior system. So you know it's one of the vertebral arteries, or the basal artery, or one of the branches off like the pontine arteries that have been affected. But you know it's the posterior system that's affected. So you can kind of start to get some of the symptoms. Is everyone good so far? Seriously, is everyone good? Okay. The basal artery will keep going to the top of the midbrain and form the posterior cerebral arteries. Oh, sorry. Why do you think it's called the posterior cerebral artery? It's going posteriorly, right? And I mean, and by elimination, what's in the posterior, portion of the brain, your occipital lobe? It covers the whole occipital lobe, the posterior cerebral artery. Everyone good? Okay. So the bottom of the skull has depressions. You guys heard me talk about the fossa. This is the posterior fossa, and the posterior fossa is the foramen magnum, and you have the middle fossa. The internal carotid arteries. This is a horizontal plane, so it's a view like this. So basically, this is your skull. Have your sagittal plane.
Dr. Ecker, we can see the side of the pool right
Thank you for telling me.
Okay.
Can you see it now?
Yes.
Okay, so this is your foramen magnum here. Again, that's where the vertebral arteries go through and form. The basal artery. Then you have the internal carotid. Again, it's on both sides, right? It's reciprocal. On both sides, you have internal carotid arteries coming in on both sides. I'm not going to draw the underside, but they go through the carotid canal. Tiny little holes in the bottom of the middle fossa. Again, so these are the holes. Again, this is a horizontal view. This is a sagittal. So saying that, this internal carotid is on the other side of the skull. So this goes up. It gives one branch that I want you guys to know because it's really pertinent. And it's the only branch that's outside the circle width I want you to know. Because sometimes people present with, have you ever heard the term amaurosis fugax? Have you ever heard the term? Okay, well, it's basically, if someone comes into the ER with blindness that goes away in an hour or two, that person's going to have a massive stroke. It's bound to happen. Basically, what occurs is you normally have a thrombus, what's the difference between a thrombus and embolus? Anyone know what the difference is? Well, one is stationary, one's not, right? But you can have pieces of thrombi break off and travel up circulation. That's what causes amaurosis fugax. You have in the internal carotid artery, you'll have a plaque, which is a thrombus. Whoops. You'll have a piece break off, travel up, and the very first branch of the internal carotid artery is the ophthalmic artery. The ophthalmic artery enters the back of the eyeball as the central retinal artery. But then little pieces will get stuck in that, but usually, sometimes your body can clear it, and the blindness is not permanent. It's paroxysmal blindness. But if someone comes to the ER with that complaint, and you let them go, that's a big problem. Or they come to your office with that complaint. Let's say they come in, they say, yesterday I lost my vision for 2 hours in my left eye. Unilateral loss of vision that is 100% a temporary cessation in flow to the central retinal artery, which is coming from the internal carotid.
Can you repeat the name of that disorder, please?
Amaurosis fugax. I'm not going to test you on that. Just a needle effect. But the first artery branch off the internal carotid is the ophthalmic artery. So if you have a tiny microemboli, pop, that's the first place it's going to go. Okay. Does anyone get that so far? Yes. You don't want to know that. Do you want to know that? I'm more than happy to tell you what it is, but I'm not going to test on that. But it's called the carotid canal. But there are holes in the foramina in the skull that the carotid arteries. It's just holes in the skull that the carotids pass through. That's it. I'm not going to test on that. So I mean, it's really not that important to know unless you're an anatomist, which one of you guys are going to be an anatomist, so who cares? So the internal carotid artery, but I do want you to know, I might ask you what the first branch of the internal carotid artery, I might ask you that. That might be one of my questions. Or I might, I'm not going to ask you what this is because that's just going too far. Ophthalmic, oh. Notice there is an H after the P. Yeah. Yes. No. The first branch off of the internal carotid artery. This is not a part of the circumvillus. The internal carotid artery will form the circumvillus at some point, but right now the very first branch off of it is the ophthalmic artery.
Could you repeat what the question is from the live class, just so we know?
Yeah, she asked if that was a portion of the circumvillus. It's not. It's just one of the branches that are exiting the internal carotid artery before it becomes technically the circumvillus. So that is not a portion of the circumvillus at all. It is just one of the branches that first comes off before it makes that nice circle. Okay. Does anyone understand so far? Okay. Okay. So is the internal carotid artery, the ophthalmic artery. The internal carotid artery continues to go superiorly, and about this is the midbrain, right? Okay. So this is hard to explain. Actually, I have a brain model to show you guys. Basically, this is going vertically, right? At this point, as part of the midbrain, the brain now starts going horizontally. So this is like the pedestal the brain is on. Okay, you guys get that? This is the brain stem is literally the brain stem, and then now you have the brain on top of it. And this is the anterior portion, anterior view. So if I'm looking at you, that's my midbrain here. Here. So from the portion of the midbrain, the brain then, the cerebral hemispheres are there, and they are not in a vertical plane; they're in a horizontal plane. Okay, you guys get that here? So basically, your brain is coming out now. The internal carotid artery is going to be in front of that, of this system, right? So it's going to be in front of the. So if I could draw it in space, the internal carotid would be like this. Okay. They're going to branch. You guys understand that? Because I know there's no way to make it three-dimensional, but you have the internal carotid in front of this, the one on each side. Basically mirroring this on one each side. They're going to give off two big branches now, and that's when the circumvillus is going to become the circumvillus. So the first branch is the ophthalmic artery. And then you have the internal carotid going up. They give off Okay, they give off a middle and anterior cerebral arteries. Middle and anterior cerebral artery. This is where that's where the internal carotid artery ends. When it branches up into those two main branches, into a middle cerebral artery and an anterior cerebral artery, that's it for the circle villus. That's it for the internal carotid artery. Can you guys see that? So it forms two major branches, the middle and anterior cerebral arteries. That's why I did this sagittal view, though. With this sagittal view, I can show you how they kind of connect. So you have the basilar artery, then you have the proximal cerebral arteries. Okay, so let's just go over this again. So you have the vertebral arteries that connect forming the basal artery. You branch up again into the proximal cerebral arteries, which go posteriorly. You have this is the internal carotid artery. It's going to branch into a anterior and a middle portion. Okay. And same thing on this side, right? With the middle portion, which really goes out that way. Goes out medially. The anterior portion. So you see the circle being formed so far? Internal, then again, so that's an internal carotid artery, that's an internal carotid artery. They're giving off the middle and the anterior branch. Middle, anterior. The one last thing the internal carotid artery does, it gives off the connecting branch, which is called, this connecting branch is the posterior communicating. It's kind of common sense. You have the branch come off the internal, going backwards, and it's communicating with the posterior system. So it's a posterior communicating artery. And then the two anterior cerebral arteries give off branches called the anterior communicating artery. And that's the circle villus. That's it. Anyhow. So you see the circle form now? Somewhat. I'm just going to draw it without the skull. I think it's going to be a little bit easier to understand. So you have, you know what I'm going to do? I'm going to do the posterior system in green.
We can see that part of it.
I'm going to turn it, I'm sorry. So posterior's in green, okay? Okay. Posterior cerebral arteries, basal arteries, vertebral arteries. Vertebral arteries come from the subclavian artery. Internal carotid artery. You guys are going to see? I'm going to do both sides. Internal carotid artery. This is internal carotid artery too. Middle cerebral artery, middle cerebral artery, anterior cerebral artery, anterior cerebral artery, posterior communicating, anterior communicating. These are closed circles, circle villus. So that's way if you have a blockage here, you have some way to circumvent that. Okay, and this side. Yes? No, this is remember the posterior cerebral artery is part of the posterior system. It's a branch, the posterior cerebral artery is a branch of the basal artery. Posterior cerebral, posterior communicating. So it's posterior communicating. It's allowing the anterior system to communicate with the posterior system. And this is anterior communicating, so it allows the two anterior cerebral arteries to communicate with one another. So it's a closed circle. That is the circle villus. in about 50% of the population, these arteries are missing. There's no posterior communicating arteries, which sucks for them, literally. Posterior communicating artery. No, not just it. 100% is genetics. That's it. Which those people obviously have a smaller stroke. It's actually a more severe stroke for them because they don't have that collateral circulation. I'm sorry, this should be off. Okay, so that's the circle of Willis. One thing I want to bring to your attention, actually, because we're going to talk about trigeminal neurology today, hopefully. Actually, we're going to talk about it now. Since it's the posterior cerebral artery. Does everyone know what trigeminal neuralgia is? What is it? Do you guys all in the Harvard branch understand the circle of Willis?
Yes.
Okay, good. So, I'm sorry to interrupt you. Just to go over again, the anterior system supplies about 7% of the blood to the brain. The posterior is about 30%. So if you have a stroke in the what do you think the anterior cerebral arteries supply? The frontal lobe, would that be a good guess? Yes, most of the frontal lobe. So if you have a stroke where you have where a portion of the somatosensory cortex is the frontal lobe, they lose what's called stereognosis. So when they hold an object, they can't identify what it is. That's an anterior stroke, anterior cerebral artery stroke. Anyways, you guys have to know that. But if you ever want to talk about it, I'm more than willing. Okay, so that's the circle of Willis, basically. But this posterior cerebral artery is actually pertinent in trigeminal neuralgia. Okay, what's trigeminal neuralgia? No, it doesn't. Yeah.
I know they get like severe headaches
right.
Inside, and it lasts for a long time.
Actually, by definition, it doesn't. It's a chronic condition, but the exacerbations last from a few seconds to a few minutes, and then they resolve. That's in order to be trigeminal. There is actually no testing for trigeminal neuralgia. The diagnosis is based on certain criteria by the International Headache Society. And there's 4 criteria, basically. But one of the criteria is that the symptoms are remitting symptoms. They're either a few seconds to a few minutes.
Isn't it demyelination of the nerve in the...
It is. It's damage to the nerve sheath and some demyelination that occurs. Yes, it is. 100% is. And the majority of cases are because this artery, the posterior cerebral artery, the cranial nerve for, what number is the trigeminal nerve? What cranial nerve is that? It's 5.
5.
Right, 5. It's cranial nerve 5. Trigeminal. 3 branches. Okay. Remember I said that this is laying on top of the brainstem? So you have your midbrain here, your pons here. Actually, it'd be more like here, because that's the medulla. Remember, these break off into the basilar artery at the medullary pontine junction. So you have pons, medulla, and midbrain. Well, the nuclei for cranial nerve 5 are right here in the pons. What ends up happening is that the posterior cerebral artery, in some people it's a little bit larger in caliber, it actually rubs against the nerve sheath of the nuclei, because you have a nuclei, and what comes from the nuclei? An axon. What happens is this artery, in some people, is enlarged, and it rubs against the nerve sheath, and it causes demyelination, 100%. That's the main cause of trigeminal neuralgia. Right there is this artery. Okay? See, it's kind of cool to know the anatomy, because then you understand that this cranial nerve arises from the pons, and it's in close proximity to the posterior cerebral artery, and that's what causes majority of cases of trigeminal neuralgia. So again, based on the International Headache Society, for clinical diagnosis, it's a clinical diagnosis. There's no testing that can be done. It's purely clinical. The first criteria is that the pain is not chronic. It is remitting. Seconds to minutes long, and it stops, and it can start back again in 30 seconds. It's just pain that keeps coming back. There are triggers to it. That's another one of the criteria. What do you think some of the triggers could be? Stress actually can trigger, believe it or not. Yeah, stress is actually a trigger for it. But also anything that uses any of these. Talking, yes. Chewing, right? Because that's the trigeminal nerve is mostly sensory. It does have a motor portion, but it's minimal. It's mostly it's actually the motor portion is for the masseter muscles, for the muscles in the jaw. Did I say motor or sensory? The motor portion is for the muscles in the jaw. The sensory is for the main branches, right? You have a temporal branch, a maxillary, and a mandibular branch. So it's mostly due to sensation. So if you have wind hit your face, it can trigger it. Blowing your nose, coughing, sneezing, eating, chewing, anything that involves anything around your face can cause it. So that's also one of the hallmarks that you may have no pain, you go outside, get hit with a gust of wind, and it triggers it. So another criteria is triggering, okay, the triggers. The third is that there's no other possible neurological problem that you could have that could be causing it. So everything else has to be ruled out. So it's a diagnosis of exclusion. You guys ever heard that term before? No questions? Yes.
No, just answering yes.
Oh, okay, sorry. Yes. Superior cerebral artery. Is cerebral artery. Superior cerebral. Not cerebellar, cerebral. Superior cerebral artery. Did I say cerebellar? I may have. I apologize, I did. Yes, cerebral. cerebral, cerebral. The artery that caused the condition in most cases is the posterior cerebral artery. Cerebral, posterior cerebral, yes. The PCA, the posterior cerebral artery. And it's actually pressing against it's actually caused by direct trauma. Literally, the artery just is pulsating against the nerve sheath and actually kills the axon, the myelin, where it is. So there's two forms of treatment, or there's a couple of forms of treatment. You have medication, which almost never works, and you have surgical treatment. The first line treatment for trigeminal neuralgia is carbamazepine. Yeah. Questions? If anyone has questions, you guys understand trigeminal neuralgia? It causes demyelination because of compression from the posterior cerebral artery. That demyelination triggers the nerve to send impulses that are not really there. You have triggers on your face because this nerve innervates your face for sensation and motor portion. So basically anything that can affect your face can cause this to trigger. The pain is remitting, it's not a constant pain. So if you have someone come and you will, I guarantee all of you will, I don't know how many people are doing, when middle-aged and older adults, someone will come to your office with this at some point, I guarantee you. And they'll be sent for MRIs and all this nonsense, which is crazy. But anyhow, it's a diagnosis of exclusion. You have to rule out other neurological conditions that can cause this. Okay? But honestly, when somebody comes to the office and presents with this, I'm telling you, it is, once you get, it's like that aha moment, you know, it's just obvious. And people who suffer from this, it is, like you have people commit suicide. There's a video on YouTube, it's really depressing, but you can just Google trigeminal neuralgia on YouTube, and it's a really crazy video. How many people kill themselves with this condition? Tons of people. Again, every neurologist is going to try medication therapy first. They'll start with carbamazepine. They'll titrate the dose up. What's the problem with that treatment, especially with older adults? What's carbamazepine? I mean, sedation, falling, slowed cognition. There's so many things. Folate metabolism, it affects folate metabolism. There's so many things that you could just name. Second line therapy would be pretty much anything else that you try. Pregabalin, gabapentin, lamictal, even some of the tricyclic antidepressants have been used. If you look at every journal article, none of them are effective. Nothing works. And in some patients, it's complete refractory to all oral treatment. You may have a reduction in the pain from like a 10 to a 7, but there's never any resolution, except a very small percentage of cases. In most cases, you need to have surgical decompression, which can be done percutaneously or open surgery. The best method is probably open. For the percutaneous method, they use different approaches. Which, honestly, guys, I'm not going to talk to you about these because I don't expect you to know the different surgical procedures. Just know that one of the main procedures of the open procedures is microvascular decompression, where they literally wrap Teflon around the trigeminal nerve. That's how they do it. They open, wrap Teflon, and they're out. And it's curative. That's microvascular decompression. Any questions? Okay, let's go to stroke since then we'll after stroke, we're going to take a break. My mouth is dry. We kind of covered a lot with stroke. What's the most common, I'm going to erase all this now. What are the two types of stroke?
Hemorrhagic and ischemic.
Right. Perfect. Ischemic. That's the term I was looking for. Because ischemic really covers all the kind of stroke that from a loss of blood supply. So you have hemorrhagic. Let's just talk about this since the circle Willis is fresh in our brain. Majority of about 10 to 15% of strokes, give or take, your source, because it varies dramatically, is hemorrhagic. Okay, so 10% of strokes, which I'm not, I will never ask you a question what percentage of what, because that's ridiculous. I don't care. That will never come from me because teachers will ask you that. I don't know what they're trying to prove. But hemorrhagic stroke is hemorrhagic stroke. The majority of hemorrhagic strokes are from berry or saccular aneurysms. Guess what? In the circle Willis, the majority of them, by far, 80%, 80+% from the These three arteries basically cover more than 80% of the hemorrhagic strokes. Anterior is number 1, posterior is number 2, and middle tubular is number 3. So majority of hemorrhagic strokes are from an aneurysm in one of these three arteries. And this is in number order. So anterior first, posterior second, and which I'm not going to ask you that either, or middle tubular artery third. So right here, you pretty much have majority of hemorrhagic strokes from berry aneurysms, saccular.
Excuse me, what's that third artery? We can't see the bottom.
Oh, I thought you were going to say my handwriting was bad. Saccular, S-A-C-C-U-L-A-R, like a sac, middle. So if I go from tangent, you guys have to stop me because I just keep rambling. So. Yeah, let me switch. I just spelled that wrong completely. I'm sorry again, I forgot you guys. I apologize. Anterior communicating, posterior communicating, middle tubular artery. Very saccular. It's very saccular, very whatever. Saccular aneurysm, very aneurysm. Okay? That's the majority of hemorrhagic strokes. Right. No. Of the hemorrhagic strokes are caused. Yes, ma'am. Yes. 100%. I mean, literally, if you have a hemorrhagic stroke, it's going to be, you can almost play the lottery. It's going to be one of these three arteries. 80% of the cases. 80%. 80+% actually. And from a saccular aneurysm. What are the symptoms? Are the symptoms of a hemorrhagic stroke different from an ischemic stroke?
Yes.
Like, okay, tell me why. How?
Sudden severe headache.
Right, that's the one thing that's really the only thing I was looking for. With a hemorrhagic stroke, the red flag is the worst headache of my life, severe headache. Right. So think headache, severe headache. That's a very specific hemorrhagic stroke. Pretty much every other symptom is very similar after that. And what are the symptoms of stroke besides of just stroke in general.
Slurred speech?
Right. Dysarthria. What else? Slurred speech, which is dysarthria. Facial drooping. Changing, yes. I mean, the list goes on. But a lot of us will, if you guys see somebody come to the ER with a stroke, a lot of us can start identifying this as probably a stroke. Especially they just said they had a case of amyloid Fugax 3 weeks before. And it's probably internal carotid artery stroke. Okay. How are we going to treat a hemorrhagic stroke? I don't know how much you're going to go into, I'm just going to cover it because I don't know how many of you guys are going to go into, like the ER or acute care. Let's just go over treatment like in the hospital, what would it be, I guess. For hemorrhagic stroke, what are we going to do?
You're going to get a scan and then a follow-up scan like 6 to 12 hours later.
Right.
See if the blood's enlarging, staying the same, or starting to resolve.
Somebody obviously works in the, yeah. Exactly. What's the first test we're going to do when somebody comes in? Right, again, without contrast. What are the components of supportive care we're going to do with hemorrhagic stroke?
Blood pressure control.
Right, keep the blood pressure controlled. What do we want to keep it under? What's the guideline?
Less than 160.
The guideline is less than 160, yeah. And I know everybody loves nicardipine, so that's why I put that there. Which is a CCB. Okay. What else? What other kind of supportive care? Are we going to keep the head of the bed flat or up? The hemorrhagic stroke.
30 degrees.
Right. And that's actually really important.
Also make sure the patient's not on any type of anticoagulation.
Right.
And check
Great point.
coagulation
Check
levels
drugs.
and make it FFP.
Right. Check coag. And now it's a little more complicated, right, with the direct thrombin inhibitors. It makes our lives a lot more complicated, right? What would we give there on a direct thrombin inhibitor? FFP, right. If it's Coumadin, what do we give? We're going to give FFP, actually, because vitamin K is going to take way too long to reverse it. It's the same answer, basically. We're going to give FFP because putting vitamin K is not going to drop the INR quick enough. So that's really not going to be used. Okay, I'll cover that in ischemic stroke. So that's basically most of what you need to know for hemorrhagic stroke. It's supportive care. If she mentioned that you're going to do repeat CAT scan in 6 hours, if it is worsening the bleed, they may do surgical intervention, which consists of multiple different methods. I'm not going to go into detail with any of them, but clipping and coiling is what's in vogue, and I think coiling now seems to be the mainstay for most interventional neurologists. Okay. Which I'm not going to ask you about clipping and coiling. I'm not going to ask you that.
At what point would they go in and try to isolate the blood?
I'm sorry.
At what point would they try to go in and excavate the blood?
The blood? It depends on symptoms. If the person is going to herniate, they would try to do it. It depends on level of consciousness, depends on symptoms. That's really symptomatic, and based on, honestly, the neurosurgeon having the case at that point. But that's open to a lot of different opinions, quite frankly. That's a good question, though.
Yeah, especially the area.
Right,
The brain
exactly,
and the
exactly.
age of the patient, if they're not a good candidate in the elderly, if they're not going to do well with surgical intervention anyway.
Right. I mean, the reality is if we try to intervene with an 89-year-old with a aneurysm of the anterior communicating artery, you're going to kill them. So, even if they're going to herniate, I guess that's a tough question to answer, actually, really tough question. And most hemorrhagic strokes, actually, I should mention, are in the subarachnoid space. So there's subarachnoid bleed. Just remember, all of the blood supply for your brain is in the subarachnoid space. All of it. It's suspended in fluid. Okay. So that takes care of hemorrhagic stroke. So now the biggie one, the ischemic stroke. Ischemic strokes, again, the majority, 85+%. Internal carotid artery is 70%. That's pretty standard no matter what source you look at. Internal carotid artery. It can be even an embolic one from it, because it could be thrombos or thrombi or thrombus that causes microemboli, right? Microembolization, right? So you have the atheromatous plaque rupture. What's a plaque? What's a plaque made of? I can't hear you. I'm sorry. Cholesterol. It's a fatty mass in the center, and it's topped up by a fibrous plaque of connective tissue. It can rupture, and then boom, you have all that stuff going everywhere. Okay, so majority of strokes are internal carotid artery. That's why if you have someone come in, you have to do. But the first thing you're going to do is CT scan with contrast. What are you going to do if you figure out it's an ischemic stroke? Are you going to see signs of that in a CAT scan? Right. Carotid. Is that going to show in a CAT scan an ischemic stroke? Yeah. An immediate? No, it's not. Not in a million years. Not in a. Yeah. No, an ischemic stroke is not going to show on a CT scan. Not initially. It won't. If it's a pretty good, it'll show an MRI in most cases. Hemorrhagic stroke, exactly. CT scan without contrast is always done to rule out hemorrhagic stroke. Period. Because what's the main treatment for ischemic stroke?
TPA.
TPA. So you have to make sure you're not bleeding before you give more, clot busters. So, okay. So thrombus, microembolization. Let me see what else I can cover. Presentation. Same thing as a hemorrhagic stroke minus the headache. Although you can have headache too, but it's not the same kind of headache as with a hemorrhagic stroke. So symptoms, history. Oh, come on, guys. Yeah.
If you had a recent fall.
Recent fall. Absolutely.
Anticoagulation.
Anticoagulation, that's from the hemorrhagic, but yes. What else?
Oh, yeah. Hypertension.
Hypertension, diabetes, smoking, alcohol, genetic prevalence, age. So you have modifiable and non-modifiable risk factors. So that's what I want you guys to know. So hypertension and diabetes is really the biggest one. Actually, I could argue smoking too. But actually, they've linked smoking to more of the lacunar stroke. Which a lot of people don't link. It's a stroke. It's a stroke. It's just of the distributary branches of the larger arteries. So it's a very minuscule stroke, but it is a stroke. And the problem is people have most of these tiny little strokes in the brain, and eventually they coalesce. Then you have a lot of damage, and you have a lot of symptoms. Most strokes in the brain stems are lacunar infarction that eventually coalesce and cause symptoms. Secondary Parkinsonism, mostly from ischemic strokes in the brainstem that affect the basal ganglia, the caudate, the putnam, all those things. Okay, so risk factors here. Symptoms same as hemorrhagic, except minus the headache, which again is not. I shouldn't really say that because that's not really true. What are we trying to focus on to prevent secondary stroke? No, what are we going to focus on? What the risk factors? Right. Right. We're going to focus on the risk factors. Basic medicine, keeping the blood pressure down, keeping the cholesterol down. This is when you get to some of your guidelines, the NCEP guidelines, the hypertensive guidelines. However, those guidelines do not apply to everyone. With the geriatric population, those guidelines do not apply, not even close. I'm not going to get into detail about this, but it's something that's really close to me because a lot of internal medicine doctors try to treat geriatrics. They treat a 40-year-old, and that's just retarded because it doesn't work. You end up almost killing the patient. You can't do that. The guidelines are very different for a geriatric patient versus a Middle Eastern.
Is that to allow the collateral circulation to form, to allow a little, not hypertension, but a little bit higher blood pressure than?
Well, actually, you know why? It's a really good question, actually. It's actually not, because most older adults develop a degree of autonomic dysfunction, and if we drop their blood pressure below, like, say, 140, no, they're not going to have a stroke, but they're going to hit their head and bleed out and die anyways. So fall is one of the biggest things once we start dropping the blood pressure below 140. And actually, the American Geriatric Society released guidelines specific for people in over 65 that covers these things like cholesterol. Like, how many 92-year-olds do you know on a statin? I mean, come on, really? It's ridiculous. And if you look at the guidelines published for older people, it's very specific. And we do things which it makes absolutely no sense because we're practicing basically not understanding what we're doing. Because there is, if you look at a 4-year-old and 8-year-old, that's 40 years between that. Would you treat a 2-year-old the same way you treat a 4-year-old? I certainly hope not, right? It's the same thing. So anyways, we want to lower these based on the current guidelines. That's why it's so hard to kind of go into like details in terms of the guidelines because it does differ based on the age of the population. So I'm not going to be asking you specific blood pressure goals for people because that's what you guys have references for, all right? And there's nothing wrong with that. If you're unsure, if you have an 82-year-old patient and you're unsure what you should keep their blood pressure down to, look it up. Not a big deal. But you should practice from a guideline because if you order in court, that guideline will. If you practice from just about any guideline which is substantiated, you're going to be fine. Okay. Anyways, moving along. So you're going to control risk factors. That's the main thing with ischemic stroke. We covered symptoms. We covered history. Let's cover some of the hospitalization. What are we going to do? What are we going to keep the head of the bed at with an ischemic stroke? Flat. Right. Because one thing we're trying to maintain is what? Cerebral perfusion pressure. What is that? Does anybody know what that is?
MAP minus ICP.
I'm going to stop you from buzzing in soon. Yes, it's MAP minus ICP. And MAP is what? You guys kind of know what this is. MAP is?
Mean arterial pressure.
Right. So it's 1/3 of systolic blood pressure minus diastolic blood pressure, which is also pulse pressure plus diastolic blood pressure. Obviously, you do what's in the parentheses first, then you do the multiplication, then you do the addition. That's what mean arterial pressure is. And MAP minus ICP. The normal ICP is about 7 to 15 millimeters of mercury. So are we going to be aggressive in dropping a patient's blood pressure with an acute stroke? No, because if you look at what's MAP, MAP consists of systolic and diastolic blood pressure. So if we're dropping the systolic blood pressure too much, we're also dropping MAP. And MAP is in direct opposition to the ICP. So if we drop the MAP too much, you're essentially going to make the field perfusion pressure 0, which will kill the patient. So the blood pressure actually is allowed to be 220. Anything higher than you can treat. Labetalol is the drug of choice. I'm not going to ask you that, but for those of you who want to go into acute care medicine, there you have it. Head of the bed flat. Why are we keeping the head of the bed flat?
Increases your ICP.
The cerebral perfusion pressure.
Right, because you're not fighting gravity. That's why. It's all about gravity, actually. Basically covered it. So drug therapy for people with strokes. Your statins, right? What else? Your antihypertensives, your anticoagulation. Let's say that it was a embolic stroke from AFib. Are we going to anticoagulate this patient? Yeah, unless there's some reason that we shouldn't. In most cases, we are. And your choice of anticoagulation is really, honestly, that's open to some people. I know guys who are old school; they will not use anything; they'll only use Coumadin. That's based on opinion again. But so, CT scan, we're going to do the cardiac ultrasound. We're going to do an echo and an EKG, right? EKG looking for AFib. Echo looking for what? Any cardiomyopathy or right. Exactly. Any valvular heart disease, anything that could potentiate this. I'm not going to ask specific guidelines for the